I'm very, very excited today about having Dr. Victoria Cherniak. It's my honor and a pleasure to introduce her to speak about principles, concepts, and applications of magnetic resonance imaging. Dr. Cherniak is a professor of radiology and urology in Montefiore Medical Center in New York, and also Albert Einstein School of Medicine. She is a leader of several things, and she has led by example. She has been a very well-known editor and author. She's associate editor of Abdominal Radiology. She is the chair of LIRAD's steering committee, and she is also the chair of Lexicon and Writing Working Group. She is the interim section chief in the division of abdominal imaging in Montefiore, director of body MR imaging. She's an instructor of GU ARRS genitourinary instructional course. So such a great educator and great author and editor we're having today, Dr. Cherniak. She's also a great friend, and I'm sure that we will all enjoy about listening to her about the principles, concepts, and application of MRI. Dr. Cherniak.
Elsias, this is such a wonderful introduction. Thank you. And thank you so much for the opportunity to give this talk. And thank you everybody who joined today, and hopefully we'll have fun. So we'll talk today about introduction to MRI. We'll start a little bit about MR physics. We'll discuss T1 and T2 weighted sequences because they're kind of the staple no matter what body type you're imaging, touch upon advantages and disadvantages of MRI. So one thing that you need to realize that MR scanner is just a humongous magnet. So this, when we talk about magnets, this is what we're thinking about, but MR scanner is a little bit different magnet. It's a coil magnet. So if you remember from your physics days, when you apply current into the coil wire like this, it will generate a magnetic field. So what MRI does is creates this ginormous coil, then houses it in the big bore, places this big bore on a stand, attaches the table, and voila, we have our MR scanner. So MR scanner is always on. You have to remember that. Once the scanner is installed and the coils are connected, it will generate B0, which is our background main magnetic field. So it is a large magnet, and sometimes you'll hear radiologists refer to it as the magnet, just like that. Again, main magnetic field is always on. So unlike CT, where the radiation is only emitted when the scanner is on, MRI is always on. And the main magnetic field of most clinical scanners is either 1.5 Tesla or 3 Tesla. There are some open scanners that are either 1 Tesla or even less. And there's research scanners that go up to 7 Tesla. But most clinical scanners, again, are going to be either 1.5 Tesla or 3 Tesla. So what happens when we place the patient into a MR scanner, place a person into a MR scanner? So as far as the scanner is concerned, people are a collection of protons because human body is full of water molecules. And remember, each water molecule has 2 hydrogen atoms, which of course are a proton and electron. So again, as far as MR scanner is concerned, we're just one big collection of protons. So the proton can be represented like this in the schematic. And what do we mean by that schematic? Well, this rotating motion is known as angular momentum. And when this angular momentum happens, remember this is a charged particle which moves, which means it creates a local kind of almost current, right? Which means it will generate a magnetic momentum, which is a tiny little magnetic field. So again, protons have this angular momentum that generate magnetic fields. And unless we sit in the scanner, all these little momentum kind of cancel each other, so we don't walk around attracting iron to our cells. But when we put the patient or person, so this is what it looks like before you get into MR scanner. Just each and every one of these magnetic fields will be oriented at random point anywhere, and they will just generally cancel each other out. So net magnetic field is going to be 0. But when we take the person and we place this person on the MR scanner, and all these little protons will now experience the main magnetic field. So you can think of all these rotating spins or protons as little magnets. So when you put little magnets in the main magnetic field, they will realign in a way that either they're going to be aligned parallel or anti-parallel to the main magnetic field, like this. It's easier, it's less energy consuming for electrons, for the magnetic field to align in such a way that it's anti-parallel to the main magnetic field, but some are going to be aligned parallel, and that's what's going to happen. So at any given moment, we can take a look at a vector of the magnetic field of any individual proton, and we can represent them as 2 composite vectors. The vector that goes up and down like this is called longitudinal magnetization, and the vector that goes like this in perpendicular is called transverse magnetization. So again, when the protons align either parallel or anti-parallel to the main magnetic field, many of them are going to cancel each other out, but there's going to be several that will not be canceled out, because remember, it's easier to be aligned anti-parallel. So the net longitudinal vector is not going to be 0. There's going to be some value to that vector. The transverse magnetization will look slightly different. So when we look on the view from the top, you can see that at any particular moment, the transverse orientation of the transverse vector is in a random position. So again, you have this billions and billions and billions of vectors, and they're going to cancel each other out. So if you just put the patient into the scanner, the net transverse vector is 0. So again, the longitudinal vector will be not 0, the transverse will be 0. So just to kind of summarize, again, when we place these magnetic moments in the external field, they begin to precess, they begin to have this kind of almost a spinning top motion. And the frequency of this precession is described by Lamour frequency, which is determined by B0 and gyromagnetic constant. And again, magnetic moments will align either parallel or anti-parallel to B0 and create a net vector. And MR image is based on manipulation of this net vector. And we will see in a second how we do that. So in order to manipulate this vector, we have to do something else besides placing the patient on the scanner. We have to put an external coil, which will allow us to give RF pulses. So we're going to put this coil on top of the patient, and the coil will emit RF pulse, which is basically an energy transfer to a subset of protons. So when the energy is transferred to the protons, 2 things will happen. One thing is, because now you have this excess energy, a bunch of these protons will flip and now become parallel to the main magnetic field. And and the second thing that will happen, if we look on top, this is a view from the top again, the protons are spinning every which way, but once we give them energy, they will actually realign and they will start spinning in cohesive patterns. So they will become what's called in sync. So we can represent the result of it by looking at the summation vector. Remember, we start out with a vector which is fully in longitudinal up and down direction. Once we give RF pulse, this will change, and the transverse vector will increase because the vectors will kind of sum up the transverse vector. And the more and more spins will flip, the less and less a longitudinal vector will become. And then when we stop giving the RF pulse, when we stop giving this energy, things will want to go back to the way they are, like this. And we can let them go all the way back, or what happens to get the MR image, at some point, we basically take a picture, and by taking the picture, the coil listens to the signal, and that signal is then is recreated into a image. So how do we form this image? You can think of MR image as a map of signal intensity of the slice. So each pixel provides a tiny little portion of the slice, and the MR image represents the map of the signal intensity of each of these pixels. And signal intensity is basically the magnitude of transverse magnetization vector. So the larger the vector, the brighter the pixel. And the magnitude of transverse magnetization vector at the time of the coil listening or acquiring the signal is determined by how fast the longitudinal vector recovered, which is our T1 property, and how fast the transverse vector decreased, which is our T2 property, and also on proton density of the tissue. You can imagine that everything else being equal, the tissue that has many more protons will have a larger vector to start with, and therefore will be able to generate a larger transverse magnetization vector. So this is an example. This is kind of like a representation, say three tissues, 1, 2, 3. These two tissues have the same number of protons, so they start out with the same magnitude of the vector. And this one has fewer protons, so the net vector is smaller. We give out RF pulse, and then these two tissues kind of relax at the same rate, but this one a little bit different. So at the time when we listen, you can see that we will catch each of these vectors at the different position, and the magnitude of transverse vector is going to be different. And again, this magnitude will determine how bright the pixel is. So a little voxel that gives you this much signal would be this gray, more signal brighter, less signal darker. And that's in essence how we create the image. So you will hear, when people talk about MR, you will hear a lot about T1 and T2 weighted images. So let's take a look at what these numbers mean. So if we look at the magnitude of longitudinal magnetization over time, and the recovery of the signal has this curve, and how fast this curve goes back to normal depends on the tissue. So we can look at the constant, which is this, and you can see that each of these tissues recovers 67% of the original length of the vector at different times. And these times are described as T1 constant. In a similar concept, if we look at the length or magnitude of the transverse magnetization vector, we start out with a maximum, and then it kind of decays over time. We can have tissue A, B, and C, and they decay, each and one of them decays at a different time. And you can see that, again, similar to T1 constant, T2 constant is going to be very different between these tissues, defining how the curve decays. So again, T1 is a constant. It's time to reach 63% of the original magnetization, longitudinal magnetization. And T2 is the time for transverse magnetization to decrease to 37% of the maximum. So that's like a little bit of physics behind T1 and T2. How do the sequence of events in acquisition of MR? So first, again, we give the RF pulse. Then a magic happens where we do different manipulations with local field. And then we do that to magnify, to magnify certain properties of certain tissues. And at some point, the coil is going to stop and listen, acquire signal. Then it's going to be a little bit of time usually, and then the sequence will be repeated. So the time that passes between the initial RF pulse and between the time when the coil actually listens is called TE. It's called time to echo. And the time between RF pulse and the next RF pulse is called TR, time to repeat. So sometimes you will hear people referring to TR and TE values of the image. If you read any papers on MR, you will see these values will be provided for the sequence. These are very important determinations. So again, TR is time to repeat, TE is time to echo. So T1 and T2 weighted sequences are a staple of MR acquisition, and by no means are the only type of sequences we acquire. There are many, many more different ways of acquiring sequences, but T1 and T2 are kind of big players. So it's important to know how certain things will appear on these sequences. So there are several substances that are known to produce high signal intensity on T1 weighted sequences. So when we notice this high signal on an image, we know it's going to be one of these substances. So one thing, a subacute or acute blood, as you can see in this patient with a brain hemorrhage. In this patient with a very bright lesion in the kidney, this is actually a result of proteinaceous content in a cyst. Another patient you can see has very hyperintense masses in the liver. And so this is from melanin in the melanoma metastases. And very important, for example, in this patient with a leg sarcoma, you can see the mass is very, very bright. And the reason why it's very bright is because it accumulates gadolinium, which is the contrast that we use for MRI. So these are the main things that gives you high signal on T1 weighted sequences. Certain stages of blood, protein, melanin, gadolinium. Low signal intensity on T1 weighted sequences can be from various reasons. For example, the most important one is the simple fluid. As here in CSF, simple fluid is very, very dark. Cortical bone, and here you can see very dark line. That's a T1 finding. In this patient with hemosiderin deposition from sickle cell disease, you can see very low signal intensity in the cortex. So that's hemosiderin. And cartilage, you can see in this knee, cartilage kind of has low signal intensity. It's also signal intensity. Now, this list is not exhaustive. Other things, of course, can be hypointense on T1. What about T2? Important things are bright on T2. Of course, simple fluid, as you can see in this patient in CSF, is bright on T2. So again, simple fluid is dark on T1 and bright on T2. In this patient, we have a very bright mass in the liver, and this is from mucin in mucinous metastatic disease. In this another patient, we have a very bright lesion in that cortical bone, and this is from cartilage in a low-grade cartilaginous lesion. And another thing that can be very bright on T2 is hemorrhage, as you can see in this patient. And this is certain stages of blood, specifically hyperacute blood and late subacute blood, will give you high signal intensity on T2 weighted sequences. But low signal intensity. When you have a lot of protein in a cystic structure, as you can see here, this is a proteinaceous cyst, that will give you low signal intensity on T2. Certain stages of blood, so this patient has a big hematoma in the right parietal lobe, and you can see that very low signal intensity on T2 weighted sequences, and this is from blood. And the blood can be either acute, early subacute, or chronic. Those stages will give you low signal intensity on T2. Calcium, although MR is not very great at picking up calcium, but when there are a lot of it, we can see it as signal void. So this was a large renal calculus. And hemosiderin, similar to T1, has a very low signal intensity on T2. Again, the same patient I showed you before has very low signal intensity in the cortex from hemosiderin deposition on sickle cell disease. What about fat? Is fat bright on T1? Is it bright on T2? Well, this is a T1 weighted image, and we can say that, we can figure this out by looking at the CSF, right? You can see CSF is dark, so we know this is a T1 weighted image. So the fat is bright. But this is also a T1 weighted image. Check it out. CSF is very dark. And now the fat is dark. How about T2 weighted image? Here's T2 weighted image. You can see CSF is very bright. Well, the fat is nice and bright. But this is also a T2 weighted sequence. Look at the CSF. And now the fat is dark. So what's happening here is the fact that fat inherently is bright on both T1 and T2 weighted sequences in the current state of mind. So very long time ago when the MR was not as fast and we couldn't acquire images in the way that we acquire them now, the fat inherently was dark on T2. But that's no longer the case because we don't routinely acquire very old-fashioned way of doing T2. So for all intents and purposes in the modern scanners, fat inherently is bright on both T1 and T2 weighted sequences if fat saturation wasn't applied. And then if fat saturation was applied, the fat will look dark. And there are multiple ways to suppress fat, both on T1 and T2 weighted sequences. Each one of them has preferences. We won't go into details of that, but just know that there are ways to take away the signal from fat, make it dark, and there are many ways to do so. So one of the things that kind of people think about is MRI and CT. They kind of compare and contrast. And one of the things that comes up a lot is, well, which one is better, right? So MR, we always think of it as much more fancy kind of exam. So does it mean that it's always better? Well, in some ways, MRI is better than CT. One thing that MRI has is that it does not use ionizing radiation. You've had a lecture by Dr. El-Sayas recently, and he spoke about how CT images are formed. And as great as CT is, it does use ionizing radiation. So that means that on CT, we're limited by radiation dose. We don't want to get extra images, extra planes, extra phases, because we don't want to expose the patients to unnecessary radiation. In MRI, this is not a problem. We are not bound by any radiation consideration. We can have the patient lie on the scanner for 5 hours and there will be no downside effects in terms of health, which means that we can acquire multiple sequences, sequences that can help us determine, detect certain things and characterize certain tissues in a better way. And we can acquire these sequences in various planes, again, which will help us get a better anatomic view of things. So here's just an example of a list of sequences. This was an MRI of the brain. This is MRI of the leg. This is our MRI of the abdomen. And you can see how many sequences are acquired for each exam. This one has 2,000 sequences. This has a little more than 2,000 images, 2,000 images. And again, we are bound by time, of course, and patient comfort, but we're not bound by radiation exposure. So that's a big advantage of MRI. And here's an example of a vaginal mass in this young woman with sarcoma botryoides. And you can see we can image this mass in every plane that we need to, axial, coronal, sagittal. We don't have to worry about exposing a young woman to radiation. So again, this is a great advantage of MRI. Because we can acquire multiple sequences. Again, I only showed you some of T1 and T2 weighted images, but there's a multitude of different sequences which will emphasize different tissues, fat, tumor, blood, cartilage, things like that, functional imaging, dynamic imaging. Again, because we are not bound by radiation, we can acquire all of these things at no detriment to the patient. For example, this is a patient with a prostate. You can see that there's a blob of dark signal on T2 in the periphery of the prostate and also in the center. And when we do the diffusion weighted sequence, these two images are part of diffusion weighted sequence. You can see that This blob has very bright signal on one part of diffusion and very dark signal on another part of diffusion, ADC map so-called. And this functional information allow us to confidently diagnose prostate cancer and confidently say that we're able to do that. So functional imaging is very important for tissue characterization. A lot of it is done in the body, in brain, and other tissues, and it's a great advantage of MRI. Another incredible advantage of MRI is that it has inherent high soft tissue contrast resolution, meaning the two structures that are next to each other, the difference between their brightness on MRI is much greater than on CT. For example, this is a 36-year-old woman who had metastatic disease, and even Dr. LCIS looking at this image will not be able to find a little metastases which developed in the left hepatic lobe. But if I show you MRI images, T2, T1, T1 plus contrast, and this is the diffusion weighted sequence, none of you will have an issue detecting this little metastatic lesion. And even knowing that these studies were done 3 days apart, so even knowing that there's a lesion there for sure, there's no question there's a lesion, when you go back, it's impossible to definitively say, or say, oh yeah, this was the lesion. So again, tissue contrast resolution of MRI is a huge advantage that it has over CT.
But Dr. Cherniak, I can see it.
LCIS has an X-ray vision, so you're much better than me. But jokes aside, it's knowing that it's there. Maybe you can detect that. You can.
Yeah, I know. Now I can play smart. Yes. No.
It's absolutely not, not detectable prospectively. And again, this is just an illustration of tissue contrast resolution. The same size of the lesion, the same, it's just the ability of MRI to show the contrast between the tissues is far greater than that of CT. Another thing is that MR has an advantage over CT is that macrocyclic gadolinium agents are safe for patients with renal insufficiency. Now, you may have heard a lot about nephrogenic systemic sclerosis, which prevented gadolinium administration for years to patients with renal insufficiency. Recently, the guidelines have been changed, and a certain type of MR agents, MR contrast agents called macrocyclic gadolinium agents, are known to be safe for patients with renal insufficiency. So there's no damage to kidneys when we administer gadolinium, as opposed to iodine, which we use for CT. And because of these changes in guidelines, now we can administer gadolinium to patients with even severe renal insufficiency, including patients on dialysis. Another advantage of MR is that allergy to gadolinium is very, very uncommon. Allergy to iodine is not ubiquitous, but it's not uncommon. But true allergy to gadolinium is very uncommon. But it's not the whole story, because in many respects, MRI is worse than CT. MRI has very long acquisition times. So, I'm a body radiologist, so I'm going to speak about body here, but, abdominal protocols usually range somewhere between half an hour to an hour. Brain and brain MRI protocols, musculoskeletal MRI protocols are often shorter, but they're still way, way longer than CT. For those of you who attended Dr. LCIS's excellent lecture, you will know that CT acquires images from head to toe within several seconds, but MRI cannot do that. Very long acquisition times. Now, it may seem trivial, but if you go back tonight and just lie down on the floor and try to lie still for 10 minutes, you'll see how difficult it is. And when I'm talking about lie still, you can't, once the patient's placed in the MR scanner, they cannot move because motion will degrade the images. So it's not an easy thing to to do, and long acquisition times definitely are a drawback of MRI. Claustrophobia is not an insignificant concern. Patients who truly have claustrophobia, they have phobia, right? So they have phobia. So imagine if you think about it, if there's something in your life that is very scary to you, if you have true phobia, or you're just scared about something, imagine having to spend 30 minutes with that fear one-on-one for a medical test. For example, I am terrified of frogs. So if there was a study that required me sit in, next to a frog for 30 minutes, I could not possibly do that. So, so patients with claustrophobia, it's a very serious issue. And often they cannot get through MRI and they will require sedation. All of that leads to a very important point that patient cooperation for MRI is essential. Far more essential than that of CT, because most patients can hold still for 5-10 seconds that CT is acquired. But to get a good MRI image, patients have to follow instructions, hold still, hold their breath when they ask to, particularly for MRI of the abdomen. That's a very, very important point. Maybe not so important for extremities and brain, but again, following instructions and holding still is important for any MRI. So if patients who are little kids, they may not be able to do that easily. Patients who are demented, patients who are have acute changes in mental status may not be able to do that. When here's an example of a patient with a cystic lesion in the pancreas. Patient was unable to hold their breath at all. And this is a pre-contrast and post-contrast TMR-weighted image. And because of all the motion artifact, it's very difficult, if not impossible, to say for sure if this lesion has enhancing components or not. This same exact patient, when they placed on CT, now you can see this lesion, because again, it's a very fast acquisition time. They're able to hold still, and now you can definitively say that the cystic lesion has no solid components. So again, in some cases, a good CT is going to be more better diagnostic study than a bad MRI. MRI generally has lower spatial resolution than CT. Acquisition of CT is sub-millimeter, and MRI, many protocols, at least in body, don't get to that level, or to get to that tiny resolution, there's a lot of drawbacks to that, including very low signal to noise ratio and very long acquisition times. MRI in general is not sensitive to calcium, so if certain disease processes which rely on detection of calcium, MRI doesn't do great. So for example, this is a young woman with a well-defined lesion in the kidney, very bright on T2, very dark on T1, not much in terms of enhancement. So if we just read the MRI, we would say it looks like a simple cyst. The same patient on CT, you can see that the wall contains quite a bit of calcifications, which is completely invisible on MRI. So again, that is one of the drawbacks of MRI as compared to CT. Another important thing is that MRI is much, much more expensive than CT. And it's not a non-important consideration when thinking about the healthcare expenditure. And finally, MRI is much less available than CT. Partially because of expense and partially because MR studies take so long, the throughput of the scanner is not nearly what the CT does. So it's much easier to get CT than MRI. And there's a list of contraindication to MRI, which we'll talk about in a second, but patients with certain aneurysm clips and certain pacemakers just cannot get into MRI because of safety concerns. So is CT better than MRI or MRI better than CT? The answer is maybe. So it's not a direct yes or no question. And it really depends on the context and depends on the patient. So for example, if the question is to assess nephrolithiasis, MRI is much worse. It's really not an indication. This is the patient I showed you before with a renal calculus, which we do see on MR as a kind of low signal intensity on T2. But notice that all these little calcifications in the medulla of the kidneys in this patient with medullary nephrocalcinosis is completely invisible on MRI. So again, patients for assessment of nephrolithiasis, urolithiasis, MRI is not the study of choice. CT does much better. But in many cases, MRI does things that CT cannot. For example, acquisition of these dynamic images where we evaluate the function of the pelvic floor. We ask the patient to evacuate that bowel on the scanner. This type of examination is not possible on CT, and we can only do it on MRI. So aside from all, a few cases where one modality clearly is indicated, another not, everything else is kind of depends on the patient, depends on the indication. Things to remember is, again, that the patient cooperation is essential. Remember, these studies are long. Patients absolutely have to hold still. They cannot move. They need to be able to follow instructions, and they need to be able to comply with breath holding, particularly if you're sending the patient for abdominal MRI. When patients don't comply, this is what we get. We get this motion degraded image. And even though this is a very fancy scanner with very good software, this image is essentially non-diagnostic because the patient was just not able to do what we need them to do. And patients may not be able to do that because they're unable to breath hold, because they have some sort of lung conditions, pleural effusion, CHF, infections, severe emphysema. So these things can limit patient's ability to breath hold. There are also some conditions within the intra-abdominal conditions that can limit patient's ability to breath hold, including severe ascites. So patients like this may not be best candidates to get MRI. And then patients may not be able to follow instructions because they've been sedated and they have tunded. Patients who have or experiencing severe pain may not be able to lie still. Patients with dementia may not be able to follow the instructions. Patients with acute agitation, acute changes in mental status may not be able to do what we need them to do. So again, if you have a patient, if you're on clinical service, and if you have a demented patient and you're considering sending them for MRI, think about whether or not this is a correct study to do. And if there's a question, talk to your radiologist to see what they have to say. So patient cooperation is important. Another thing to remember is the safety. Remember, as I said previously, the MR scanner is always on. It's never turned off. It doesn't matter if there's a patient in or not, the scanner is always on. And magnetic field is very strong. So this is what happens if safety instructions are not followed. So everything that is brought into a MR scanner has to be marked as MR safe. All the equipment, and there's no exceptions to the point where if the patient is having a coding on a MR scanner, the patient has to be taken out of the MR scanner of their MR room before resuscitation is started. Even the crash cart cannot be brought into the room because it will fly into the bore, and there's no way to take this thing out of the scanner without quenching the scanner, which is basically unplugging it, which is very expensive and lengthy process. And you can imagine that this is a very dangerous thing, because if the patient is in the bore and something flies right into it, it can damage the patient pretty badly. So safety instructions must be followed very carefully. If you ever go down to MR scanner as part of clinical team, don't think that people are being mean to you. We're just being very careful and really are concerned about your safety. A fun fact, if you walk into MR scanner, don't have your credit cards on because the strong magnetic field will destroy the magnetic strip on your credit cards. So those are safety concern. And there's a list of contraindication to MRs. So most patients with pacemakers cannot get an MRI. Now there's new, very, very recent pacemakers which are MR compatible. They're uncommon and patients have to have documentation, and it's a very lengthy process to get these patients on the scanner. But in most cases, patients who have pacemakers cannot go into a MR scanner, even if the pacemaker is unplugged and disconnected, because the concern is that the strong magnetic field will induce the current in the wire and then wire will discharge. Similar idea, cochlear implants, neurostimulators are not allowed in a MR scanner for the same reason, that the strong magnetic field may induce the current in these structures and they will start malfunctioning. Some surgical clips are not compatible, most are, but for example, some older aneurysm clips are not compatible. They are ferromagnetic, which means that they can move if they're placed in the external magnetic field. And you can imagine this is not a great idea if it's inside the brain. So if you have a patient and you want to send them for MRI and the patient has a history of an aneurysm clip, the patient has to have a special card that comes with a clip that will be declared as MR safe. Finally, very important safety consideration is that gadolinium in pregnancy. It is contraindicated because gadolinium can cross blood placenta barrier and be deposited in the fetus. It's unknown if that creates any kind of long-lasting effect, but this heavy metal deposition in the developing fetus is unwanted, to say the least. So the indication for gadolinium is basically if it's a life or death situation for the mother, then you can give gadolinium. Really, I cannot, in the past 15 years, come up with a single plausible example where this would hold true. So for all intents and purposes, gadolinium is not to be administered for patients who are pregnant. So to summarize, what we talked about today is, remember, a MR scanner is a large magnet. The main magnetic field is always on, which has implications for safety and things like that. MR image is acquired by manipulating magnetic vector of protons. Remember, protons have these spinning magnetization spins, create these vectors, and we can manipulate the net vector in multiple various ways to create an image, which is basically a map of signal intensities in each slice. Remember that simple fluid is high on T2 weighted sequences and low on T1 weighted sequences. That's one of the ways for you to tell which one is which. Also remember that T1 and T2 is by far not the only sequences that we have in our arsenal. There are plenty of others, but T1 and T2, of course, are our main samples. MRI has a lot of advantages, including its great soft tissue resolution, ability to do multiple sequences in multiple planes. But remember, it also has disadvantages. So it's not always clear cut whether or not MRI is the best study to go. So just because it's fancier, it doesn't always mean that it's the best path for this particular patient. So in order to get a good image and good diagnostic study and good diagnostic answer, we have to have appropriate indication before the patient is placed on the scanner, and we have to have appropriate patient selection. So again, patients who cannot comply with lengthy study, patients who have severe claustrophobia, patients who are unable to follow instructions should not get on the scanner unless there's absolutely no other way to get the answer that we're seeking. With that, I thank you so much for your attention. If you have any questions now, I'm happy to answer them. If you have any questions later on, please feel free to email me.